resuscitation. He is the editor for the AAP's textbook of Neonatal Resuscitation 7th and 8th editions, and a member of the Neonatal Life Support Task Force for the International Liaison Committee on Resuscitation, otherwise known as ILCOR. He is a member of the American Heart Association's Guidelines Writing Committee, and of note, he happens to be a phenomenal educator who is a return faculty speaker at this symposium, the first one, as well as many other meetings such as NeoPrep. He will speak on moving forward in NRP education, improving the old and embracing the new. We have given him an extreme challenge of staying in a stationary position, because if you've ever seen Dr. Weiner speak, he is a mover. He has to go up and down the rows and engage the audience. So be kind and please welcome Dr. Gary Weiner.
Okay, got this on top of my head. Is that working out? Okay, thank you so much for that.
Is your mic on?
Clara. It is really a pleasure to be here and return to the Sooner State, see so many of my friends, and then online see nearly 400 participants who also share a passion for resuscitation. And
Is your
today I'm
mic,
gonna focus on
Gary?
education.
Is your mic on?
Is that better?
Yes.
Okay, all right, again. But it is in the context largely of North America. And so much of what I talk about is relative to our international colleagues, but I will be speaking specifically about the NRP and its implementation in North America. Speaking before Congress in 1961, President John F. Kennedy inspired a nation. He expressed a bold vision. He said that, "I believe that this nation should commit itself to achieving the goal before the decade is out of landing a man on the moon and returning him safely to Earth." He expressed that vision with a specific goal. He got a nation ready to move ahead by expressing that timeline. He didn't know how we would do this. He didn't know how we would get men to the moon and return them safely home, but he believed that our nation could do it. It was a bold vision. Because of that, just 8 years later, Neil Armstrong and his Apollo 11 crew, supported by a huge team, made that vision come true and landed on the moon and gave us one of the classic quotes of all times. So in 1987, the AAP and NRP also expressed a bold vision. This was when there was the very first rollout of resuscitation programs dedicated to newborns. And they expressed a bold vision. At the time, their vision was we would have an NRP trained provider at every birth. You're having trouble. Any better? Let me know if I need to help with audio up here. Okay, anyhow, so they expressed their vision in 1987, and it was to have a trained provider at every birth. Next slide.
It should let you do it. It's
Okay,
the clicker is, yeah.
the clicker's not quite good. Anyhow, and in 1987, that truly was a bold vision.
Yeah.
And in 1989, as the intern on the far left in this photograph, I was one of only the second class of pediatric residents trained in NRP at the University of Michigan's residency program. And since that time, imagine where we've come. Since that time, over 4.5 million providers have been trained in NRP. The materials have been translated into over 20 languages, and it's been used in over 100 countries. Millions of babies have been impacted. But is that really still a bold vision? Is that a bold vision today? We know that in the United States, Over 1,000 babies every day and 35,000 babies worldwide need assistance getting their first breath started. They rely on skilled providers, first to do initial steps, but often to do complicated steps under time pressure and under tremendous stress. And we rely on them to have tremendous skills right in the delivery room exactly when it's needed, not delayed, but without haste when it's needed. And is expecting that these providers train once every 2 years and having a trained provider, is that really the best we can do? Is that the standard we should be holding ourselves to today? I believe that poor quality resuscitation is a preventable harm. And I think we can commit to better. I think we can commit to a stronger, bolder vision today. I believe and I propose that we should have a vision that says, during this decade, we will commit ourselves to having a provider who has mastered the essential skills of resuscitation at every delivery, and a master team available for every resuscitation. So what's needed to accomplish that? The ILCOR education and implementation team, in their guidelines, they have described 3 things we need to do. We need to optimize resuscitation science and practice. That's the role of ILCOR and your steering committee. We need to optimize training and education, and we need to optimize local implementation. Chelsea, next slide. Thanks. And today, I'm going to focus on just the middle one. I'm going to focus on education, training and education. Now, those of you that are with us today who are instructors, and I imagine many of you are instructors, you know, when you come to a course, there are challenges you face. When you walk into an NRP course, you have a room full of people with different levels of experience. They have different needs. Their job requirements may be different. You have limited time available. And too often, when you're teaching, people in the room have other things on their mind. They have other commitments that they're thinking about as well that interfere with the time you have with them. On top of that, the material we're teaching includes 3 different learning domains. There are cognitive skills, the factual knowledge. There are technical skills, the hands-on things, and behavioral skills like teamwork and communication. And then further complicating that, each of those domains potentially has different methodologies that are ideal for teaching them. And they have different rates of decay for each of those. So again, for instructors, a tremendous challenge. Next slide. And you're faced with adult learners. And adult learners, they come to you with experience. That experience impacts the way they'll learn. It impacts the way they interact with the other learners in the room and with you. In addition, adult learners are motivated by what they perceive is immediately relevant to to their daily lives and their daily job. Oftentimes, the perceptions of what's relevant may not really be accurate, but they walk in with those perceptions. And we know that adults learn best when they're motivated, when they have the time to reflect on the experience they've just had and incorporate it into their existing knowledge base. In addition, your adult learners will have preconceived learning styles, preconceptions about their own learning styles when they walk into the room. And finally, your adult learners who are learning resuscitation with you at the warmer, they fear appearing to fail in front of their own colleagues. If you have a senior neonatologist taking your NRP course, trust me, they fear looking bad in front of their colleagues and their junior colleagues. And that can interfere with how adults learn. Next slide. Too often, our courses have focused on teaching and the teacher rather than learning and the learner. Oftentimes as instructors, we've seen ourselves as jugs full of knowledge, and all we have to do is pour it into our learners. We just have to transfer our knowledge that way into learners. And frankly, in our courses, we have spent a tremendous amount of time pouring our knowledge, but oftentimes we've missed the mark, we've failed. And instead, those of us who are parents or have had little siblings, we know, advance the slide just a little bit. Thanks, Chelsea.
Sorry.
We know that motivated learners provided with, back up. Thanks. We know that motivated learners provided with adequate materials can learn without being taught. And this is not a new observation, not a new observation at all. If it goes back 400 years to an educator named Johann Comenius, who observed in his experiential teaching program that he seeks a method by which teachers may teach less, but learners learn more. Next, Justin. So where have we been? Let's look quickly at where NRP has been. Of course, one of the foundations of NRP has been the textbook. Going back to the very first edition in 1987, it included 6 lessons, and providers took a handwritten test during classroom time. And I spent many hours as an instructor correcting tests with the little bubble sheet. If you go forward to the 7th edition in 2016, that included 11 lessons and an online exam hosted by HealthStream. And our current edition that we just released is well over 300 pages with 14 lessons, and I'll tell you about the exam in a moment. In NRP, over time, lectures with PowerPoint slides became the dominant focus. The NRP course in its first edition was never intended to be a lecture-based course. It was very hands-on experiential, but over time, instructors demanded slides, and we provided them with PowerPoint slides. By the 5th edition, the most amount of time instructors used in their class was spent giving lectures from PowerPoint slides. In lessons in the 5th and 6th edition, we gave the option to give an abbreviated course. You could do just lessons 1 through 4 and 9, the ethics lesson. At that time, lessons 1 through 4 included the basics all the way through chest compressions. But then with the 7th edition, we said as a steering committee that everybody who takes the course should take the entire course. Very early on, right from the beginning, there were skill stations and a mega code. But what we recognized was that when we evaluated your skills, it was isolated from the team. We evaluated your skills as an individual and told the people standing at the warmer not to assist you in any way. Can you imagine the model that we were encouraging people to use at the bedside? Recognizing the importance of teamwork and communication, with the 6th edition, we required a component of simulation and debriefing. Next, Chelsea. Of course, as an educator, one of the questions you're going to ask is, do participants in an NRP course actually learn what we think they did? And here in a study published by Megan Gray, evaluating the eSIM online micro simulation that NRP had, she looked at cognitive skills and how do people learn cognitive skills immediately after completing a standardized course. On the image here, you see steps along the algorithm in the middle. And then on your left in blue, those bars show the percentage of participants immediately after a course that did it correctly. And on the right in red are the bars that show the percent that didn't do it correctly. And what you'll see is approximately half of providers immediately after completing a course incorrectly perform many of the steps of Mr. SOPA ventilation corrective steps, incorrectly or failed to actually identify whether the mannequin was actually intubated, and about 20%, 1 in 5, ordered epinephrine incorrectly. And this is immediately after completing the course. Next. And so what happens a little while after completing a course? We know that both knowledge and skill decay. Knowledge is reasonably stable. At least in a study, 80% of residents that completed a course passed a ventilation knowledge test after approximately 1 year. But skills decay quickly. Among a group of residents at Children's Hospital of Philadelphia who were monitored, after 2 months, 90% failed the NRP ventilation skills test. And by 4 months, everybody failed it. They primarily failed it because they were unable to complete the ventilation corrective steps. Similarly, a loss or decay of skills has been demonstrated by providers completing the Helping Babies Breathe course just 1 month after the HBB course completion. Next. So what kind of strategies can we employ? The ILCOR implementation group identified a number of strategies. I'm going to focus on 5 of them today. Contextual learning, distributed practice, mastery learning with deliberate practice, debriefing, and innovation. So contextual learning. If at all possible, deliver your course in an environment that mimics the real world practice where your providers will be. Here you see an image of one of my teams taking a course right at the resuscitation bay where they actually work. That way they're in the environment. Teaching has context. And motivate your learners by structuring your course so that the content is relevant to their real world scope of practice. If you're doing simulations, consider developing scenarios that are based on patient safety events that were reported in your hospital, a potential upcoming delivery that you know about. If you have a high-risk mother who has a baby with a chylothorax, your simulation could include pleural effusion at the time of birth, restricting ventilation. So bring it home, make it contextual. Next slide. In order to support contextual learning, the AAP this time is now offering for the 8th edition, again, 2 levels of learning, NRP Essentials and NRP Advanced. NRP Essentials focuses on lessons 1 through 4. The basics of resuscitation foundations, the initial steps, positive pressure ventilation, including mask ventilation and a laryngeal mask, a laryngeal mask, a laryngeal mask. It's about time. It's been in the textbook for, I think, 15 years now, a laryngeal mask. And it does not include compressions and medication. It is focused on people who will be initial responders. Each hospital, each organization will determine who takes which level of course. The advanced course is lessons 1 through 11. There are 3 additional lessons in the NRP textbook this time, lessons 12, 13, and 14. Those focus on improving teamwork, on resuscitation outside the delivery room, and bringing quality improvement to your hospital. Everybody can take those lessons. There's no test on those. And so you'll determine who takes lessons 1 through 4 or the entire course. If you have any doubts whether you should take the entire course, I encourage you to take the advanced. Next slide. The next strategy is distributed practice. When we think about new learners and acquiring new knowledge about NRP, we know that new learners have a limit on how much capacity they have in their working memory. If a new learner wants to cover all the content in the 8th edition NRP, there are 14 lessons, over 300 pages of text, a complicated algorithm, and multiple skills and concepts to go over. That's an enormous cognitive load for anybody to acquire in a 1 half-day or 1-day course. It will overwhelm them. Next slide. And so our traditional training, though, has really focused on compliance. Did you check the box? Does everybody have an active NRP card? Rather than on competence. Can people perform the skills in the delivery room with mastery? And that's because we've used traditional or mass training. We use high intensity training. Courses last multiple hours, but very low frequency. We see our learners once every 2 years. And because of that, because many learners may not have enough opportunity to practice skills between these infrequent training events, their skill rapidly decays as demonstrated on the cartoon on the right. An alternative is distributed or spaced practice, which is low intensity practice, potentially only a few minutes, but with high frequency, daily, weekly, or monthly. And we've known in a number of different settings that this distributed practice helps learners to not only maintain their skill over time, potentially actually grow and develop their skills. Next. And think about if you were the trainer and you were responsible for Miguel Cabrera's base padding practice, again from Detroit. He's a designated hitter, first baseman. He hit over 500 home runs recently. If you were responsible for his batting practice, would you advise Miguel to spend 2 straight hours in the batting cage 1 day a week? Or would you advise him to spend 20 minutes in the batting cage 6 days a week? Trainers and athletic trainers know better than we have, apparently, that short practice frequently is much more effective. Yes. And so for your new learners, consider this option. Consider instead of 1 4 to 6 hour course, several short courses separated in time. You might have 60 to 90 minute sessions where the first one introduces initial steps and PPV. The second one introduces laryngeal mask and intubation skills. The third one introduces chest compressions and medications, while your 4th session focuses on simulation and debriefing, teamwork and communication. Think about dividing your course instead of trying to throw it all into 1 day. Next. And of course, the benefits of distributed practice, they're not limited to just the initial course. They're important for maintaining skill as well. As an example, a 1 day, looking at Heather Ersdal's her research group, a 1 day Helping Babies Breathe course in Tanzania improved simulated performance at the completion, but there was no improvement in delivery room outcomes. However, by simply adding brief 3 to 5 minute weekly practice and monthly longer retraining sessions, next, they were able to decrease early mortality from 11 to 7 per thousand. Again, refreshers and short retraining sessions are very important for maintaining skill. Next. And this has been shown over and over again in multiple settings and in multiple resuscitation settings. We've seen that brief retraining with an OSCE, which is incorporates an assessment. And we know that assessments themselves, the process of being tested, adds to your learning. Doing that every 3 months has been shown to retain PPV skills among PEDS interns over a year. 2 minutes of practice every 3 months doubled the retention of pediatric compression skills. And 6 minutes of practice every month improved nurses' CPR skill retention. Short, repeated practice is a concept that we should adopt. Next slide. Our next strategy is mastery learning and deliberate practice. Mastery learning, that concept suggests that everybody has the potential to become an expert. It's just a matter of providing the right training and the right amount of training. And we shouldn't accept a minimum standard. We should accept only a mastery standard. As a parent, as a family, you have a right to demand that expectation of the people attending your child's birth. Mastery learning deliberate practice, it involves the idea that we create specific, clear, demonstrable learning objectives. We have focused, repetitive practice that includes informative feedback and a measured performance with a clear mastery threshold before you pass, before you're finished. Next. Again, going back to sports, think about if you go onto the golf course and you just swing away, you can swing away for many hours. You will have a lot of practice under your belt, but all you'll be doing is cementing bad habits. Instead, if you spend a shorter amount of time with focused goals, with a coach, a pro who knows what they're doing, and today can actually measure the velocity of your swing, the angle of your swing, how quickly your club head hits the ball, the angle of the takeoff of your ball, the distance, you can measure outcomes. In a very short time, with informative feedback, you can become a master at your stroke. Well, you'll get good at your stroke. It's the most frustrating game in the world. You'll get much better. It'll improve your stroke. While just going out on the course, you can spend hours and you won't get any better. In fact, you might get a little bit worse. Next. And this was reflected by famous coach Vince Lombardi from the Green Bay Packers, who said, "Practice does not make perfect. Only perfect practice makes perfect." And we need to improve the practice. Next. And we're getting there. In NRP, we're getting there. We're not there yet, but we're getting there. This time we're replacing for the Essentials course for lessons 1 through 4, the old cognitive exam with a new concept called True Adaptive Online Learning. It's a method where when you start the experience, you'll be asked a question and about how confident you are in your answer. And then depending on your confidence in the answer and how you answer the question, you will be provided with additional content to bring you to a mastery level before you then face questions again. And it will adapt to the mistakes that you make. You'll get the content you need. If you've mastered the content when you arrive for the assessment, you'll get through it very, very quickly. On the other hand, if you haven't mastered the content, it will take you much longer. Next. And the performance checklists and integrated skill stations were intended to be a mastery learning standard, but we haven't really gotten there yet. And we need to support our instructors. We need to support our instructors by developing measurable performance standards. We need to deploy tools such as censored mannequins, respiratory function monitors that can help instructors by actually measuring the performance and showing the performance of the learners at the bedside. We have some of these methods available and they're becoming more available now, but it presents challenges. As an instructor, how do you manage your classroom? How do you manage time? What do you do when the learners in your room require different amounts of time to achieve the mastery standard? This is clearly a challenge, but it cannot stop us from developing and demanding a mastery standard. Next. One possible solution is to use or adopt methods, contemporary methods of self-directed education. With self-directed education, we can help learners to acquire and practice basic skills outside the classroom. This may take the form of short videos to introduce skills or censored equipment for practice. And years ago, with a very basic mannequin, the early edition of the neonatally HBD mannequin, we showed that learners doing self-directed education at home can acquire basic skills just as well as their colleagues who took a classroom course. Next. And the beautiful idea of self-directed education is it supports adult learning. It's flexible. You can use it at the time of day that's best for you. You can do repeated practice at your own pace. If you need to go back over a skill, you can do it as often as you need to, while one of your partners who's doing self-directed education and already has that skill may quickly go through it. So it's flexible. It meets time schedules. It avoids experienced people embarrassing themselves in front of their colleague, because with a self-directed program, you may be able to practice in your living room where nobody can see you and practice that two-hand hold over and over again until you get it right. And the benefit of it, moreover, is that if your learners arrive at the classroom with their basic skills mastered, it allows the instructor to focus their time instead on advanced skills that you can't practice at home or in self-directed education, and on simulation and debriefing. So it can streamline our courses and allow you more time. Next. A new strategy that NRP and AAP is offering this year incorporates a number of these different strategies, and it's called RQI for NRP. RQI for NRP is available to those hospitals that subscribe to RQI. It is an alternative delivery method for the NRP Essentials course for lessons 1 through 4. It incorporates much of what we talked about. It's a self-directed program that uses high frequency, low intensity, simulation-based mastery learning with deliberate practice. And it's a methodology that's already been, although it's new to NRP, it's a methodology that's already been deployed for BLS, ALS, and PALS. Next. And this is what it looks like. This is what RQI for NRP looks like. It's a kiosk that's ideally deployed in a convenient location, like on a patient unit. It includes a censored mannequin, a positive pressure ventilation device, and a laptop. And what happens is users will log in quarterly using their NRP Global ID. When they arrive at the kiosk, they'll receive a brief cognitive instruction. They may participate in a cognitive activity, and then they'll have an assessment completed. Then you'll stand at the mannequin and verify your positive pressure ventilation skills, potentially learn a new skill during that quarter, and you'll get feedback from the computer and the virtual instructor. And you'll need to meet a mastery standard with your positive pressure ventilation skills to continue. If you don't, the virtual instructor will help you. Once you're completed, it renews your e-credential for another 3 months. And your e-credential, rather than your NRP e-card, is simply renewed every quarter as you participate. Next. This is what the automated feedback on the screen looks like. And you can see with the screen, much like some of those videos that Peter just showed you about ventilation, you'll be able to see how you're delivering ventilation to the mannequin. And it will give you immediate feedback on your head position, the mask seal that you're maintaining, the pressure you're delivering, and the ventilation rate that you're giving. Next. And although RQI for NRP is brand new, it has been tested in a test cohort in the United States, and we do have some emerging evidence from adult and pediatrics. We've seen that staff members have high compliance arriving at their quarterly activities, and it's been demonstrated to improve chest compression quality both in simulation and in real resuscitations in both children and adults. Now, clearly, chest compressions is a very focused technical skill, and it is potentially very amenable to practice at a self-directed mannequin. It's not entirely clear that the NRP skills are quite as amenable to the RQI methodology, but we're going to learn more. In one of the pediatric studies, it certainly had the appearance that the benefit in chest compressions may have come at some cost to ventilation quality, and we'd be clearly concerned about that. So watch, stay tuned as more evidence starts to emerge about this new method of delivering the Essentials course, RQI for NRP. Next. This is what it looks like if you're RQI Essentials as a new learner. And given our time, I'm just going to skip over this in the next slide fairly quickly. We can talk about it during discussion if you'd like to, how you actually get NRP for RQI done. So let me pass this slide and the next one. The next strategy to talk about is debriefing. And of course, debriefing is a key portion of every NRP course and certainly should be at every actual event. And debriefing, of course, it can fill an entire seminar. And I don't consider myself an expert. So I'm going to keep very brief with debriefing today. It is clearly an opportunity for reflection. It is where people really learn about their simulation, about the activity. With NRP, we encourage you to focus your debriefings on teamwork and communication. Make it a facilitated discussion. There are a number of different models for debriefing. I particularly like the mnemonic or the mnemonic GAS for gather, analyze, summarize, but there are multiple different models. In this model, as the instructor or the facilitator, you'll ask open-ended questions. Ask questions that start with the words what, why, how. Always avoid questions that start with did you. With did you, you're going to get a yes, no answer. You want open questions. What, when, why, how. And encourage your participants to talk to each other, not to the instructor. You want to encourage self-reflection and self-discovery. Use short, and I mean not quite yet, short, and I mean really short targeted video clips to support your debriefing. And of course, allow silence. Once you ask a question, count to 7 before you as the facilitator says anything at all. Get comfortable with silence. Now, for those of you who don't have an expert like Taylor Sawyer depicted here to help you with debriefing, there are resources available. Next slide. So if Taylor Sawyer isn't immediately available to you or someone like him, we have a number of resources. So the instructor toolkit on the new NRP learning platform, which you can get to at this URL, nrplearningplatform.com, provides a number of resources on the instructor toolkit. In addition, the American Heart Association has tremendous tools for post-event debriefings. And that's at the American Heart Association website. And if you follow this QR code, it will take you directly to those tools. Next. The last strategy I want to talk to you about is innovation. Innovation includes a number of things that we can look for down the road. This includes serious games, like the NRP eSIM that was available for the 7th edition, but sadly won't be available for the 8th edition. It's simply too costly to deploy, and the development costs and time, we just can't continue. But there are others, like the Retain game that's developed by our colleagues in Alberta, George Schmolzer team. That's a board game that helps you learn your skills of resuscitation. There's virtual reality and augmented reality, teleeducation, interactive film, and community engagement. Let's talk about a couple. Next. Sometimes the language gets confusing. Virtual reality or augmented reality. Virtual reality is when you're completely immersed in experience and it shuts out the real world. Imagine something like the game Minecraft VR, or if you're transported into a virtual delivery room. While augmented reality is where digital elements are added to the real life view. Think like Pokemon Go, or if in NRP, we were able to project an image of a baby's lungs, liver, and heart actually on their own chest. That's augmented reality. Next. Virtual reality and augmented reality, they're particularly good at helping learners to recall content knowledge and practice decision-making skills using voice commands. The Academy of Pediatrics recently released the AAP Pediatric Emergency Care Virtual Reality Program for EMS providers. And using voice recognition, it allows EMS providers to be immersed in a series of pediatric emergencies. And with voice recognition, they can speak to their virtual partners in the room, the avatars, and have to make decision-making. Of course, more complex models include haptic or tactile feedback, where you can actually practice technical skills like intubating or placing a chest tube. But that's more complex because you have to not only be able to see the laryngoscope where it is, but you have to feel the pressure against your hand. And beyond just the cost of development of these materials, one of the other challenges is that about half of adults, including myself, get motion sick or cyber sick with virtual reality. You know, the minute I put those goggles on, I start to feel pretty sick. And within a minute, I have to take them off and I'm all warm and have to go outside. So that's a challenge. With technology, it's getting better. Next. Can we advance it? Oh, okay. It's not advancing. My spot. All right. I'll back one more. Oh, let's see. Go back. There you go. HPV. Terrific. And so Rachel Umron from Seattle has demonstrated that even a very simple virtual reality program that uses a smartphone and Google Cardboard Google Cardboard can support virtual reality in the Helping Babies Breathe environment. In a randomized controlled trial in Kenya, Nigeria, she demonstrated both the feasibility and the effectiveness of virtual reality to allow users to practice their decision-making skills in the HPV environment. Next. And we know that neonatal expertise is a limited resource. And in small hospitals across the country, rural hospitals, small hospitals, many providers may have had no opportunity to practice their skills between their NRP courses. And we found that telehealth is a way to bring expertise to the delivery room. Similarly, and particularly because of the pandemic where we're trying to limit physical exposure, teleeducation is a way that we may be able to bring the limited resource of skilled instructors who know how to run simulations, know how to debrief simulations, right to the education setting in rural or smaller hospitals. This is also not new. Dr. Aziz and Kern studied this 20 years ago in Canada and demonstrated some problems which we need to overcome, but teleeducation with video conferencing now that's much easier and censored mannequins may support being able to bring experienced instructors wherever they need to go without lots of traffic. Next. Another strategy is highly emotional interactive film. These are short films that can be easily distributed on the web and have a tremendous impact. This is an example of an interactive film developed by the UK Resuscitation Council. I strongly encourage you at lunch today or after the symposium is over, go to this URL, life-savor.org.uk. Look at it today, tonight, and have your teenage children, neighbors, babysitters do this video. Watch these series of videos. They are fantastic. Next. You can also download them as an app to your phone. And on the left, if you have an Apple product, look at that QR code. On the right, if you have an Android product. Get those on your phone and see how interactive these short films are. They focus again on adult CPR, but this is a technology that could be incorporated to NRP. And of course, our community partners. We can't forget about the creativity of our community partners. This is a creative educational solution developed by in the community I live. Can you play the movie?
Here's open.
Maybe? Cannot play media. Well, no problem. All right, one more time. Well, these things happen. For those who are live today, I will show you the video another time today, and then I'll make sure that you've got the URL for the video for those who are not live. Can we go back to the slides?
Yeah, try to get it.
And for NRP though, we've had the Bright Ideas seminar, the Bright Ideas workshop at the NRP Current Issue seminar, and we learned fantastic ideas from our community partners, and we have to continue to encourage that. Not all of the good ideas are going to come from the small group that's the NRP steering committee. Many of the best ideas are going to come from our community partners, and we have to encourage that. Okay, in terms of practicality, for those of you who are preparing to teach the 8th edition, current instructors should have received an email back on August 2nd or 3rd from this site, and go there to have access to the instructor toolkit. And if you can't find it, then you can send a quick email to this NRP support at rqipartners.com and you'll get immediate help. Next slide. Okay, so let me summarize again. I believe that poor quality resuscitation is a preventable harm. And today, at this time, we have to commit to a bolder, stronger vision that in this decade, we will have a provider that's mastered the essential skills at every birth and a master team at every resuscitation. Next slide. And we can do it. We can do it if we believe there's a preventable harm, and that if we optimize our approach by bringing context to our learners, transitioning to a distributed learning platform, adopting mastery learning with distributed practice, with deliberate practice, not just repetitive practice, and if we debrief our simulations and contribute to innovation. Thanks for your attention today.
Thank you so much, Dr. Weiner. I would love now to ask our discussants for this talk to join us for a chat. Here with us in person is Dr. Melissa Carbajal. She is she's an associate professor of pediatrics at Baylor College of Medicine and Texas Children's Hospital. Her medical training began at the University of Texas Medical Branch and Galveston School of Medicine at Baylor for both peds residency and neonatal fellowship. The primary focus of her academic work is the role of spirituality in clinical care and medical education. Her work contributes to the understanding of using a scholarly approach to faculty academic pursuits and culture building for training programs that are experiencing difficulty. She has served on the Executive Council for the ONTPD, the Organization of Neonatal Perinatal Program Directors, and she is a member of the Executive Committee for the National Neonatal Curriculum. She is well known for promoting a growth mindset approach and physiological safety in learning environments, as well as mentoring her fellows for balancing parenthood with clinical and scholarly demands. We can all relate to that, right? So joining us virtually is Dr. Megan Gray. She is an associate professor of pediatrics at the University of Washington. Her training began at the University of Washington Medical School, residency at Children's Hospital Los Angeles, and fellowship at Children's Hospital Philadelphia. She has been primarily interested in healthcare professional education as the focus of her academic work, and she has contributed to the understanding of adult learning, fellow education, and e-learning. She has served as a co-chair for the National Neonatal Curriculum and is past chair of the Academic Pediatric Association Simulation-Based Medical Education Interest Group. That's a mouthful. And is an incoming executive council member of the ONTPD, Organization of the NP Program Directors. She is well known for a pragmatic approach to teaching adults the skills they want to build, and we are honored to have them both on the program today. So, thank you for being here. Let's start off with some initial thoughts or questions from our discussants.
Thank you so much for the presentation. It was very exciting. I will say, as a neonatologist, I have a deep interest and feeling of that we need to all be specialists and have an expertise in NRP. But as a medical educator, I was so excited to hear so many adult learning theories now being integrated into the teaching of NRP. And so I heard spaced learning versus mass learning, which comes from desirable difficulty, work by Dr. Brewer. I heard ideas about communities of practice when you talked about debriefing and talking to the peers. And so I just love that we are bringing the science of medical education into NRP. And so along those lines, the work by Amy Edmondson on psychological safety, she initially started this work to look at outcomes and performance with group activities, and she found that the more mistakes groups made, actually in the end, the more successful they were, because when they made mistakes, they talked to each other, they learned from those mistakes, and then they were more successful in the end. But that is only possible when you have safety, you have the ability to, there's a promise that there won't be punitive action, you won't be identified as an incompetent team member. And so I'm just wondering your thoughts on how we might create learning environments with more psychological safety. There are a couple of things we're trying to do, but you're the expert here. So I would love to know your thoughts on this and how to start implementing these things, because you mentioned our adult learners we have a fear of failure. And, Megan's study on, the students learn something or learners learn something, and immediately there was a disconnect. And it makes me wonder, is it because they didn't feel comfortable asking questions during the training because of maybe a lack of psychological safety?
Yeah, I think that's a great question, and I'm not an expert at creating safe learning environments, but I do think that when it comes to simulation, some of the things we can do are adopt lessons we learned from Stanford, from Luke Laman, in terms of setting expectations right at the front, making sure that we maintain that simulation is a serious activity. It's not. There's no laughing. It's serious. What we're trying to simulate and what we're learning is about children's lives. And when we make the focus about children's lives and not ourselves, that helps to establish, I think, a safe learning environment. I think contracts and expectations for what happens in the simulation environment. I think that the more often you do it, the more comfortable people become exposing themselves in the simulation environment. And even things like video, the first time I used video, so many people were uncomfortable, but over time, you just forget the camera's there. And even, Zoom. When we started in the pandemic, and I kept, like I am right now, seeing myself on screen, it was very difficult but you just get accustomed to it. So I think some of it is getting accustomed to the simulation environment, setting expectations early, making it clear that it's okay to make mistakes. And in fact, you learn from your mistakes. I tell my learners all the time about the year I was an intern. There's a terrible mistake that I made. And the next morning, my PICU attendant pulled me aside, in maybe at the time not such a gentle way, and explained to me the mistake I made and the impact it had. And I will tell you, although that was many years ago, I have never made the same mistake again. And so we learn from our mistakes. And the great thing is having the opportunity to make those mistakes in simulation instead of on our patients. And so when people understand that, when you make it clear, and then how do you run your debriefing, I think that goes a long way. And let me defer to Megan.
Yeah, I really think that figuring out psychological safety has so many challenges in NRP because you're bringing people in that may not work together. You're bringing people that may or may not have a pre-existing hierarchical relationship to the space. And, you can say this is a safe learning space and we're not going to take, any thoughts on your performance out of this space, but you can only say that about yourself, right? And I think it is really important to take the issues that come up during the simulation, turn them into a positive by the end of the session so that people walk away with the feeling that we all grew. Not only did I learn from my mistake, but you learned from my mistake. And that's going to be how we build together.
Yeah.
Megan, I think that's really key, that you can also learn from the mistakes that the people around you make. And getting together as a group that multiplies the opportunities for learning. That's a great thought.
Absolutely, I agree with that completely. And I think being explicit about our intentions, being clear that Nathan Sundgren is a part of our NRP group at Baylor, and he starts every session saying, we have a basic assumption that you all are very competent, and that whatever happens here, it's because if there is a mistake made, it's because you're out of your element, you're being watched. And so this is a forced environment. And so it sometimes puts us out of our element. And so starting with that explicit, and then Megan, to your point, the idea of turning these mistakes into something positive, that's definitely sort of a growth mindset perspective. Carol Dweck talks about what is your favorite failure, and maybe potentially even at the end of every debrief asking what was everyone's favorite mistake, and using that vernacular to make it something that is good and positive. So, I love that.
Love that idea. I'm going to use that.
Yeah, I'm going to steal that too.
Oh.
So I was just going to say, I think we've done a lot of what we've done in NRP has been in person because that's where we've been. But with COVID, so many things are moving virtual. And I know Megan's an expert in that area. I'm happy to share the platform here.
I was going to ask a little bit about that. So Gary, you showed us ton of really cool technology solutions. And I know there's people in the audience wondering, what does that cost? How am I going to get that for my program? There's small programs that are asking themselves that, you know, if I could only buy one thing, or if I only had this much money, what should I do? What of all of these technologies are really good investments for programs that are cost constrained?
Melissa, what do you think? I'm tossing that for a
If
second.
we want to take a pause and think about that, we've got some questions from the audience.
So, you know, Megan, I think it's great. I think actually, you know, one of the things is that now, because of the pandemic, we have all become so much more comfortable with distance activities, distance learning, even asynchronous learning. And I think, again, the video components are becoming very inexpensive. The NRP has provided with things like the ability to put a patient monitor on your phone and use that. So there are a number of solutions now that are very inexpensive. And I think I can't think of a particular technology myself, that I would invest in. Of course, it's lovely to have really high-tech mannequins. And certainly I think of the things I have available to me now, the ability to actually measure positive pressure ventilation performance is wonderful. I think that's a really cool new addition.
I was going to say that exact same thing. If you could just get one, I'm not an expert in technology, but I would say if you could just get one of those mannequins that you could use for the self-directed learning, what an advantage that would be. Because the way you described people being able to practice their skill set and then show up to training sessions with already a little bit of experience, both bolsters their confidence, probably makes the session move along faster.
We have a question from Dr. McCarr.
Thanks, Gary. That was an excellent. That was an excellent. That was an excellent talk. So it's amazing to see how far like technology has advanced and it's helping with the promotion of education. So my question is related very much to teleresuscitation and teleeducation and where we are in terms of committees investment into it, because teleresuscitation is amazing to see what difference it can make. There are just a handful of groups in the country who are currently doing it with the challenges involved in it. You showed like what we can do. It will be amazing to have one of those babies, like for state of Oklahoma, I can say, which we can go around along with implementing teleeducation, because I like your idea about these short, frequent practices are more effective. But in order to do that, there are barriers, like we don't have like time to go out in periphery again and again, but it could be done through teleeducation. So coming to the question is NRP looking into investing into like a chapter or module or guidance for people like us, say, who are invested like in teleresuscitation and looking into teleeducation part to guide us? What's the best way to do it? What are the unique challenges that comes with it?
So the question is related to whether the NRP is investing in teleeducation, telesimulation. At this time, I should say, from my standpoint as the textbook editor, I'm not aware of a commitment to supporting teleeducation, telesimulation, specifically from the NRP, the NRP Steering Committee, or AAP. Certainly, we are learning a lot from colleagues like in Minnesota, Jen Fang's group, that's done so much with telehealth and extending the expertise across networks. And that's now really extending. And at the NRP Current Issue Seminar, we've had the great opportunity to hear some of that specific from Dr. Fang. I'm not aware of anything immediately coming, but that is a great topic, both for an instructor update and potentially lesson 15 of the 9th edition that we're already starting to work on. But are you aware of other initiatives from other groups beyond NRP that are starting to work on telesimulation, telehealth? And Dr. Kenneth Rain is in the audience right now as well, who might be able to shed more light on this.
So we do have Dr. Rachel Umaran, who will be
I was
joining
going to
us.
say, Rachel Warren is here.
Rachel.
She had an expertise in e-programs and telemedicine.
Well, hello. I was here and I was listening, but it is kind of early here on the West Coast. What was the specific question that you had for me?
Rachel, are there initiatives to really extend the use of tele-simulation, tele-education to try to bring that limited resource of experienced instructors to more to hospitals that struggle, that have smaller hospitals, rural hospitals?
Oh, absolutely. And actually, after I respond, I will say that Sarah Berkelhammer's here too. And she has even more expertise in this space. But for our group, we have tested out both small and large group telesimulation. We've used several different platforms. Again, all this was facilitated by the pandemic and some of the early needs to continue simulation even during the COVID-19 response in 2020. So we've used combinations of specialized telehealth platforms along with Zoom. We've utilized Google documents, kind of a Google Doc, a collaboration tool built in with simulation to extend telesimulation to medical students who are distributed learners, or had been during the pandemic. And we've had really good success with a number of tools, including, so the virtual recess room is a free tool that uses Google Doc collaboration along with Zoom. We've used another tool from the ACP, so the American College of Emergency Physicians, called the Telesimbox, that utilizes Zoom along with a video, so canned video along with lots of instructor tools that come prepackaged and are completely free. So again, really thinking about low cost resources that are freely available and can be used with students who may not have access to technology or mannequins, which is the key. If you're trying as an instructor to deliver simulation to learners who may be in their homes, not together in a simulation location or center, then you need to think outside the box, because you may not have mannequins at the point of the learner for them to practice. So they need to find other ways to engage and to practice during the simulation. And so I'm going to actually ping Sarah Berkelhammer, she's still on, in case she wants to speak briefly about the efforts that are ongoing to extend telesimulation within the HBB space of neonatal resuscitation.
And actually, I can also speak about that.
Oh, fantastic. Go ahead.
I believe it's coming into a session later in the agenda too.
Yeah, so in my talk later on in the session, I'll talk a little bit about what we're doing with Helping Babies Breathe and a digital platform that we're developing with Laerdal Global Health to teach the new WHO Essential Newborn Care course, which is fully grounded in HBB as a digital course. And we're supporting that with Laerdal's new product, the Neonatal Live mannequin, which, Gary showed a picture of the neonatal mannequin that you normally fill with water, and she replicates the floppiness and weight of a newly born baby. The Neonatally Live cannot be filled with water. It has different technology embedded within her that connects to Bluetooth. You can actually monitor how your learners are practicing from afar. So Sarah has been part of a group that's been rolling out ENC now in Nepal. We have a Gates grant to pilot this in Nigeria and Bangladesh. And so we're very excited about this possibility, especially as a COVID response when people cannot gather and facilitators cannot travel. And so I echo the point that Rachel made that this doesn't have to be expensive. There are ways to do it in a low-tech way. But I hope that gives you a taste of what's to come.
Right, so stay tuned for Dr. Cam Athran's talk later today.
And Rachel was kind enough to put links to all of those free resources in the chat for people who want to explore those for their home programs.
Do we have any questions from the chat room, or actually we'll go over to Nathan real quick?
Hi, Dr. Weiner, thank you so much for that talk. I want to go back to your concept of, you were talking about coaching and using the coach analogy, something that I've been using for a couple of years in our NRP class. So there's two sides of it, the learners for them, but there's also the instructors. And I tell them all the time, I want you to think of yourselves as coaches. Don't go in there and lecture them. Let them do the practice, watch it, and then like a coach, observe them, make corrections to it. And then I go into the room and I find them lecturing all the time. They can't help themselves. And I wonder what you have for that from the instructor side. What do you do to help this concept of our instructors thinking of themselves as coaches, being a little bit more in the background and allowing themselves to be the content expert that can direct them when they're struggling, but not taking over and becoming the lecturer?
It is so hard. Just ask me. It is so hard not to lecture. I mean, lecture, it's kind of what I do. And even among my trainees, sometimes you'll see it's hard for me not to interrupt. It's hard for me not to break into a lecture during debrief. I struggle with that personally. I think one strategy you can employ is essentially what NRP talk about, debrief the debriefer. And I do think that filming a coach, coaching a learner, even as part of your instructor development program or course, film it and debrief it, and don't say anything. Just play the video. Let a coach watch themselves coaching, facilitating, coaching, instructing. And if they break out with a lecture, watch their face as they watch the video and see themselves breaking into lecture or pushing the learner aside to demonstrate how to do it correctly. You'll watch that on their face, and they will self-discover that, oh, look what I did. And again, you can use debriefing in that method for reflection, self-discovery. In my experience, that doesn't necessarily solve the problem. Because again, myself, I'm aware of that problem. I'm aware of that tendency for me to do it. I have to keep reminding myself. When I'm coaching or teaching in my own setting at home, I do ask at the end of our session that the instructors sit together and debrief the course. And that's an opportunity, I think, again, to remind people like myself who know better, but slide into old habits and help them to understand that.
Yes.
So I think the video has a great opportunity to show it and allow people to self-discover and recognize where they've gone wrong.
Yeah, as Atul Gawande says, everyone needs a coach. No matter how good you get, we all need a coach. So Bobby Byrne.
So Gary, you're awesome as always, and thank you, Megan and Melissa, for commenting. These are great. I'm struck a little bit as I listen to the conversation we've talked a little bit about how during training, it would be great for inexperienced learners to bring them back on multiple occasions instead of having one long course. And we've talked about, trying to help our facilitators to be better coaches. And we've talked about what modalities we should invest in. And we talked a little bit, and Vina talked a little bit about, being able to electronically monitor your learners from, using Bluetooth. And it strikes me that we still need facilitators to do all this. And when I think about simulation and trying to instruct, whether it's trying to help our facilitators get better or our learners get better, we need more people. We need more trained facilitators. And that's something that I think we don't talk enough about investing in. So I just wanted to comment on that and hear your comments.
Bobby, I think it's a tremendous comment, and you're absolutely right. It's an investment, and it's an important investment. It's an investment that's just too easy for our colleagues in administration to cut when you need budget cuts, right? And expert facilitators, expert instructors, they're a limited resource. It takes a long time to get someone to the point where they're an expert facilitator instructor. I'm so lucky that in my own setting at home, we have a crew of truly skilled NRP instructors. And we rely on that. And we've had at least the benefit of some commitment to support having instructors financially. But it's an investment. It's something that, again, our patients and families deserve. And as neonatologist pediatricians, we have to advocate for it. Thankfully, I think technology can help us, again, by doing things to make it more efficient when we have that commitment of face-to-face time with an instructor. When we have that opportunity, we need to make the most of it. And so if we can shift some things out of the classroom, like with self-directed learning, like with the potential for like the RQI kiosk, where you can spend some time getting your skills in great shape before you come to the instructor-led event, that can help us to be more efficient.
I'll put the same question that I'm sure Melissa and I have the same answer on this, that the fellows are at the prime place in their learning journey to become facilitators. They're still in a growth mindset. They're still in a I make mistakes that I'm learning from right now place. They have a lot of hands-on time in the delivery room. We require our fellows to become instructors. They may not go on to become lifetime teachers depending on their pathway, but every one of them has the potential to be. And if all of the fellows nationally were able to become NRP instructors during that time, I think that would give us more facilitators as a group.
Completely agree with you, Megan.
Yes.
And similarly, I require our fellows to become instructors.
Here, we are all nodding in agreement up here. We have
All
some
program
questions.
workers.
Yeah, yes. We have questions from the chat.
Yes, there is a lot of good discussion in the chat about the use of the word mistake during the debrief, and what are some suggestions on the type of verbiage or wording that you would use to put the focus less on the individual and back toward the team?
So I personally, at our institution, I don't have any problem using the word mistake. I really think that it's an honest explanation about something that happened. Mistakes are not intentional. So when we're honest about, hey, it was a mistake. I either didn't interpret the scenario appropriately and I made a decision using different data, or I wasn't experienced. I didn't have the experience to make the decision that was expected of me. And so from early on, there is, when we talked about psychological safety, I don't think that's something we can isolate just to NRP training. It has to be a culture. And so our training programs, our divisions, our sections, there needs to be a culture of this in general, so that when we say the word mistake, we don't think, oh, I'm in trouble. We think, oh, I have something to learn. And so that's not an overnight transition. That's not something that we can change right away. But again, as we're dealing with adult learners, I think that if we try and use different words for that, they know what we're doing, right? I mean, it's not like we're going to pretend that they're going to, that they get it, they know, they deep down know that it was a mistake. That's why there's a fear, right? But I think we just have to change the way we think about it rather than change all the words that we use to describe it. But it is, I will be the first to admit, it's a long process and it's not something you can just change overnight. You have to have a lot of stakeholders. Your entire faculty has to be on board with this kind of thing. It can't be a punitive environment. And then when you start to make headway in general, then more specific tasks like training NRP, training procedures, that feeling of, I mean, I have fellows now ask me, like, so what did I do wrong? And they want to know. And I think it promotes this idea of them asking for feedback. So initially, I think we can say things like, what might we have done differently? And that's sort of a way to work around the word mistake. But in general, if we start to get comfortable with it, I think it just benefits us in general.
Any other questions from the chat? So if you have any comments about that, Megan, we'd love to hear it.
Yeah, I think you have to your audience a little bit to figure that out. It's like the fellows are very high level learners. Faculty, when they come through NRP, they're there for that growth mindset, mistake-based things, and the volume of mistakes they make is much lower. But we have quite a bit of lay midwives and really challenging learners coming into our space that they don't exist in our psychological safety in our learning environment. They're here today for a conscribed task, and they're going to make a ton of mistakes. It's really hard. I think you have to know who's here with you today to know if it's safe to use the M word, or if you're really going to try to stay in the what could we do differently? What do we wish had gone differently sort of space, so that people feel like you're not adding to their internal monologue of, I did so many things wrong.
Thank you for that. And we also do have Nicole Yamada here later with us, who is a debriefing expert and studies specifically standardized communication, who will probably be able to elucidate much better than we can about the specific verbiage and Googlenomics method. But we're excited to get to that. And thank you so much to our discussants. Thank you, Gary Weiner. We will move on to our next talk.
Thank you.
Oh, not the next talk, it's break time now. So we'll be breaking for exactly 20 minutes. And then starting again.
I pushed the keyboard advance